UHC as it is, or as I early understood of it, it's a very noble idea. It is an idea that, when well implemented, can sort out a lot of issues to do with healthcare services in this county. However, I think that the idea was a bit rushed without actually doing enough survey or enough assessment of the needs and, of course, making the necessary plans for it. By the time the UHC was launched in Kisumu, when UHC was launched, that means there was a free access to healthcare. Now, the free access to healthcare made all the patients who are sick at home and they had not been able to access healthcare to start coming to the hospital. Then there was no plan for cross-border referrals. Like, for example, I'm working at Kisumu County, but there are referrals from Homa Bay County coming into Kisumu. There are referrals from Siaya County coming into Kisumu. There are referrals from Busia and Kakamega coming into Kisumu. And of course, Vihiga and Nandi Hills and Nandi County. The counties that are bordering Kisumu are also coming into Kisumu because the healthcare services are actually free within Kisumu County, and it's expensive in their county, or it's charged in their county. Now, what that means, what that caused was that there was an overburdening of the human resource that was already there, because what they did is there was increased workload without increased human resource and without increased supplies, because up to as long as I can remember, the supply from the national government has not come down. And that means then that the little resources that were allocated without UHC in mind were already strained. You will walk into a ward, there is no file, the gloves have been finished, and a lot of those little equipment and supplies that needs to make your day-to-day practice running are not available. And again, the same number of human personnel to attend to almost double or triple the normal number they normally attend to every day. So there was a strain in the human resource. There's been a strain in human resource. There is a strain in the medical supplies. There is a strain in our equipment, that you find that some of the equipment even goes, they heat up and they cannot function. For example, you want to do full mammogram test, but you find that the machine has been running throughout the day, and because of that, it heats up and it cannot continue, or probably you get errors in your recordings. So the idea per se is a very good idea. There are so many gains that have come with it. But I think that there are also, the idea was rushed, and the report we are getting and what is actually happening within the corners of those hospitals are very different. When there is dysfunctional system, the quality of care goes down. If you have one medical ward attending to all the patients with the TB, some are also probably immunosuppressed, and because there is no organized system, or there are no facilities to probably isolate other patients, then one patient coughing to 20 other patients whose immunity are compromised, then what is going to go down. All these people are going to catch the disease, and that happens frequently. So when the systems are dysfunctional, the quality of care go down, the human resource are strained. And when the human resource are strained, if I can comfortably see 30 people and you give me 100 people, then that is what will make even the interaction between the patient and the doctor not to be as good.